Hello, everyone. I'm coming to you again, and I know that this is a somewhat recurring message. And first of all, I'm indebted to the Egyptian Venous Forum for the honor of being able to present this lecture at this time. And my message is repetitive because it's designed to help prevent the number one preventable cause of death around the world from surgery or hospitalization, and that's fatal pulmonary emboli. There is no question that a thorough risk assessment is the key to this because it will pick out those people who will benefit with anticoagulation. The anticoagulation must be given for the period of time shown to be in clinical trials to be effective. This is not an easy task to collect all of these data. We're continuing to look for new ways to continue the data. So with that in mind, I would like to begin. These are my disclosures. Here I mention the leading cause of death, which is a fatal pulmonary embolism. You can see the large embolus here in the pulmonary arteries. And what's important about this is that a thorough risk assessment can protect a lot of patients, many, many patients. These brief risk assessments are fine, but they only cover certain factors. And if a person has other factors than those covered in the shorter lists, then they're not being protected. The other thing is we make a big mistake these days because we're giving anticoagulation for a short period of time. Now, if you had an infection and you were given an antibiotic, you will be given that antibiotic for the period of time shown to eradicate the infection. You don't just get it for a few days. You don't just get it while you're in the hospital. You get it for the time of a period of time shown to be efficacious in clinical trials. Excuse me. The same thing holds true for anticoagulation. The efficacious time proven starting in 1975 and reproven and reproven and reproven all these years, I don't know why we still don't get it, is 7 to 10 days for the average risk patient and even higher for the higher risk patient. And you know, the sad part about things today is, despite all of the articles and all of the research and everything that's going on, pulmonary mortality, pulmonary embolism mortality is on the increase during the past decade. Now, the other thing is that astonishes me when you look at some publications regarding prevention and thrombosis issues in the COVID-19 pandemic. It's like we're starting all over again. We seem to have forgotten what we've learned. A thorough history and physical identifies those likely to develop a VTE. Now, I know that's hard to do with a lot of acute infections and people coming in seriously ill. So we have to devise ways to collect those data ahead of time, and we'll discuss some of that today. The omission of critical family history and obstetrical complications can lead to a fatal or serious pulmonary embolism that could be avoided if those things were known and put into the algorithm. And not everybody fits into the same shoe. We have to take a look at the individual patient risk factors that we call baggage. And I've recently been involved in a large evaluation worldwide of in orthopedics about all of the risk factors associated with orthopedic patients, and we're trying to come to a consensus. And there's a lot of focus on the incidence of thrombosis for various orthopedic procedures. But what's not been included is that the procedural risk for a venous thromboembolism is only part of the story. The other part of the story is the baggage that the patient brings to the table. For example, a patient can have a very low risk of thrombosis because of a simple operation, an appendectomy, a knee arthroscopy, but be carrying such a high level of baggage, family history of thrombosis, previous thrombosis, cancer, chemotherapy, inflammatory bowel disease, or a combination of all those, that makes that patient, although they're having a low risk procedure, qualify for a lot of prophylaxis, maybe even 30 days. The other thing about this process is that careful patient selection minimizes the bleeding risks. And here's another thing that I find hard to come to grips with. If you give a prophylactic dose of anticoagulation and you get some bleeding in the patient, that may cause them some disability on a temporary basis, or if it's an orthopedic procedure, they may not get the outcome they were expecting, but they don't die. Whereas if they're high risk and you say, oh, gee, I can't give them anticoagulants because I want a good outcome, that outcome may be good from the orthopedic standpoint, but the patient may die of a fatal pulmonary embolism. So we have to keep these things in mind. A fatal event from a prophylactic dose of anticoagulation is a medical curiosity. Experience worldwide using the Caprini score remains poorly understood due to the lack of updates from national guidelines. I find this really very frustrating. I am so indebted to people from 5 continents studying the score in over 5 million patients and over 200 studies. And they haven't been all patting the Caprini score on the back. Most of them, yes, they found the Caprini score very useful to lower the incidence of venous thromboembolism. However, what hasn't been said is all of those people have also come up with certain problems associated with their implementation of the score, inability to score it properly, certain surgical procedures that maybe aren't properly scored in the system. So we get, if you'll excuse the expression, the good, the bad, and the ugly from all over the world. Well, I think it's important and one of our duties to share those information with others. So that's why you're seeing me present these data frequently and over again in order that people will get the message about what's going on, and we will be able to share and benefit from our wonderful colleagues from all different countries, nationalities, and so forth, different patient populations. They all fit together to help us as a world community to lower the incidence of fatal pulmonary embolism. Now, we know that there are obstacles to this collection of data. It's hard to collect all the data, especially during an emergency. We have some lessons, and I'd like to share some of those lessons with you, including the experience from Boston University, talk a little bit about machine learning and other tools in order to make this process easier. We know the Caprini score is a thorough history and physical. We choose it not because of the name, we choose it because it's a thorough history and physical tested in 5 million patients. We know as the number of risk factors increases, the incidence of venous thromboembolism goes up. We also realize that these factors have different weights. And when they're put together synergistically, they make a combination of risks that's greater than the individual risk alone. And this synergistic combination, including the number of risk factors and the power of risk factors, leads to a simple score. And that score increases in proportion to clinically relevant venous thromboembolism events. Here you see the results in general surgery. Again, I would like to reemphasize that this has been studied in over 5 million patients, and we have a lot of experience with this. And I'd just like to show you some various studies that illustrate how different populations have to be evaluated differently. You can't put everybody in the same shoe. Talking about, well, as a routine we use. I don't like the word routine. We have to be selective, and we have to make sure that we give exactly to that patient what that patient needs based on their risks. And I'm very indebted to the CHEST 2012 guidelines, because for the first time, they acknowledged the use of the Caprini score as a way to evaluate patients in individual risk assessment. Now, they also talked about the Rogers score, which is a very interesting score in trauma patients, but later by 2015, another study was done that showed the Rogers score really didn't work that well as originally planned, and it really didn't catch hold, but the Caprini score caught hold. And one of the things that caught hold, and I know that all of us around the world, we'd like to follow the guidelines. It's often been said, if you don't follow evidence, it's just another opinion. Well, I may disagree with that in a little bit, but in general, we follow the evidence. And the CHEST consensus guidelines told us in 2012, if the Caprini score was 5 or more, there was a 6% chance of a person getting a blood clot, a venous thromboembolic event, without prophylaxis. Well, now in 2021, that's just not true. And we know that, for example, look in general surgery, 5 to 6, 1.3%. Look in head and neck surgery, 5 to 6, 0.9%. Look in plastic surgery, 1%. That's not 5 to 6%, is it? But then look what happens all of a sudden when the set point goes up to over 8, 6.5% in general surgery, 11% in plastic surgery at 60 days, by the way, and 18% in head and neck surgery. So it's very important that we learn. How do we learn all of this? We learned all this from all of you wonderful people around the world. Many of you in the Middle East that have done tremendous studies in this regard, and I'm indebted to all of you. But it's all of us holding hands together that is producing these results. And it's important to get these results out. And that's why I put this stuff out weekly, in order to keep trying to emphasize the importance of these data and to bring people up to date. Because unfortunately, the 2019 ASH guidelines didn't include any of these data. Now let's take a look at some ways to collect these data. We know that people like to be involved in their medical care. And here we've developed, not we, but wonderful people around the world. Look at all these languages, look at all these countries. And a patient-friendly risk assessment has been validated. Now, what does that mean? That means that these people took and gave the risk assessment to a group of patients. Patients filled it out, turned it in. Then those same patients were interviewed by doctors or people, allied health personnel skilled in taking histories and physicals. Could be a nurse practitioner or physician assistant. And the results compared between what the patient wrote and what the interviewer got. And there was a very good correlation between those. So then going forward, this risk assessment was validated in all of these languages and shown to be a very valuable way to collect data. And this is the simple form. Now, I'd like to mention two things that are unique to this. If any of you have ever had a family member with a history of blood clots, or any of you have ever suffered, or anyone in your family, an obstetrical complication, those are missed in every other risk assessment model out there except for one. And both of those we have. The obstetrical complications are very important, and we'll discuss that later, because that means the patient could be a hidden carrier for a thrombophilic defect or defects, which could make them very risky for having even a minor procedure. This is where we come to baggage, and we'll talk more about that. The other thing is family history of thrombosis. I am astonished that there's only one other risk factor score in the world that I know of that documents specifically family history. And we know that that's the British Department of Health VTE risk assessment tool from the National Health Service. We know that they made that mandatory, and as a result of that in the United Kingdom, deaths from pulmonary embolism went down over the last 2 years. Why doesn't everybody else get that? Why don't they get the British experience? Who knows? In any event, let's go back to obstetrical complications. Specifically, I'm talking about recurrent unplanned abortions, stillbirths, premature birth with toxemia, growth-restricted infant. Patients with any of these historical events may be carriers of one or more of the following abnormalities: lupus anticoagulant, anticardiolipin antibody, beta-2 glycoprotein, either 1, 2, or 3 of these. And depending on whether they carry 1, 2, or 3 of these, it may indicate that they're at higher and higher risk for thrombosis, especially if they carry all 3. And they can carry these defects through their life long after the obstetrical events are over. And this is often missed. Now, is it common? No, it's not common. But it's a tragedy for all of those women of the world that have had these complications not to have that counted in their risk assessment in order to protect them when they have operative procedures. So let's talk about family history. This is another thing. Scandinavian countries have produced some wonderful epidemiological studies. The way their health systems are set up, it makes it very, very attractive for them to do this. This is a study of 183,000 patients over a 25-year period with matched controls, taking a look at family history of venous thrombosis in relatives. So what this presumes is, if you're a patient without a personal history of a blood clot, but you have a sibling, son or daughter, or parent your risk of, who've had a blood clot, your risk of thrombosis is increased. If you've had a maternal half sibling, a paternal half sibling, a niece or a nephew, your risk is increased, but a little less. If you had a cousin, it's increased even a little less. And for spouses or people that live together, it's also slightly increased. And the thought there is that people that live together have sometimes common lifestyles. Very, very important study. How often, all of you in the audience, wherever you are in the world, you think of all the times you've interacted with medical people and are going to have an operation or you get sick. How many times have they specifically asked you, have you had a family history of a blood clot in a relative, first, second, or third degree relative? Now, we came upon something by accident, but again, because I decided to get involved in this wonderful global thrombosis forum. And this is a charitable organization that was put together by these beautiful people, Atul Ladoo and his wife. And they're dedicated to increasing the education and scientific knowledge of young people from around the world, especially from third degree countries, but don't make any difference where they're from. It's dedicated to teaching people at a very young age about these. And I know even my wife said one time, he said, you know, Joe, when you get people in practice for a long time, they're pretty set in their ways. But if you could get to them early and teach them some of these things that you're trying to get across at a very early age, then they will carry them through to the next generations. So here is two students. And we realized that this was a powerful tool for completing risk assessment data. So we got these students to collaborate with their family, and I'll describe that in a minute, how they did that. And then if you could get these results and verify them with a physician and put them in the medical record as a baseline score. It's just like when you have in your medical record, do you have any allergies? Do you have any past illnesses? Have you had cancer? That's in your medical record. And when you go to the doctor records all of those. Why don't you have a risk score in your medical record? Well, this is really, I think this is a secret weapon. We never envisioned that this would work as well as it did. So these were two high school students from the Global Thrombosis Forum that distributed a brief explanation of what venous thromboembolism was and the patient-friendly form. And they went to the principal and they got approval to give it to their fellow students and for them to take home and give it to their families. Now, any of you in the audience that have any children or grandchildren, and they come home with homework, I think that most of us are very anxious and very willing to help these kids with their homework. And that's exactly what happened. In a 1 month period, we got 1,219 completed responses. And those responses included 22% who said they had a family history of thrombosis. Almost 60% were 41 years of age or younger. This wasn't an old age population. 28% were overweight, 10% were hospitalized with infection or swollen legs, and 9% had insulin-dependent diabetes. Now, what we concluded from this is elective completion of the patient-friendly assessment with family members prior to any illness and having the results validated by the family physician and placed in the medical record is critical, since at the time of an emergency, a thorough patient history and physical is often incomplete, especially regarding family history of thrombosis and history of past obstetrical complications. Now, one of my colleagues told me, he said, Joe, you know, this data is biased. And I said, well, how's that? Well, you know, naturally, parents and grandparents are going to help their children with their homework. And also people who have a family history of thrombosis are more likely to participate in the survey. And I said, don't you get it? That's exactly the point. That's exactly what we want to try to do, is to get people to network together, get their histories together for these more obscure things, get them in their medical record so that when they come into the hospital, bingo, they have a baseline. And if that baseline shows a Caprini score, for example, that's over 10, boy, you better pay attention to that. I don't care how minimal the procedure is that you're going to do on them. Now, that's one part of the problem. Another thing I want to talk about is that you can create all the algorithms in the world with all the data in the world and set up nice little things. And we're going to show you a beautiful algorithm from Boston University about how that was done. But unless there's mandatory implementation of the algorithm, there's a disconnect, just like the rider and the motorcycle. And this relates to execution. And reducing VTE deaths requires a mandatory implementation of appropriate care. That man has got to be, or that person could be a man or a woman, has to be on the motorcycle, if you will. Now we take a look at Boston University, which is a wonderful university in the Boston area in the Northeast, and they were very embarrassed. They had a high incidence of venous thromboembolism, and this shows their incidence in July 2008 compared to the green baseline, which was the national average. So, oh my goodness, we got to do something about that. So they put some programs in place, and oh boy, by July 2013, they had reduced the 30-day VTE events, including deaths, to 0.1%. How did they do that? Well, they had a mandatory risk assessment protocol, which called for 7 to 10 days of prophylaxis. If the patient had a score of from 5 to 8. Now, that's 7 to 10 days. Didn't make any difference where the patient was. They got 7 days of low molecular weight heparin injection. 89% of people followed that protocol. And if the score was 9 or above, they got 30 days of low molecular weight heparin. And the compliance was 77%. Now, how did they do that? Was this some area that took care of affluent people? No. One of the responsibilities of the Boston University was deal with and take care of indigent patients in their area. And they did that very well. And they made a deal with the drug companies that any patient that needed this injection would get it free of charge, regardless of their ability to pay. I mean, if they could pay, that's fine. But if they couldn't, they were all supplied the drug. So isn't this wonderful? Suppose this is the poster child for America and also for the world, I think. But the conditions in America here are such that if every hospital in the United States did what the Boston University did, including supplying the drug to everybody that needed, we'd get a very low incidence of venous thromboembolism. So this is the poster child. Now, I'd just like to review the fact that the Caprini score works for medical patients. Well, now, what kind of a statement is that? You mean to tell me if you do a thorough history and physical, and it's mostly been tested in surgical patients, that the thorough history and physical doesn't apply to medical patients? Well, we know that's not true, and we have data to support that. And the Chinese have done some wonderful studies, as of others have around the world, showing that with the Caprini score of 5 to 6, there's a 3.3-fold increase in VTE. Here in 7 to 8, it goes up to 9.4, and it goes up to 24.69 if the score is over 9. That same escalation, you'll see that wherever you go when the score is done properly. Now, in addition to that, now, first of all, I have nothing against the Padua score. It's a wonderful score, very brilliant, because what it did was take a few items and make sure everybody got those items done. And so it protected most of the patients. And that's fine. But when you compare a brief summary to a full summary, it's no wonder that the sensitivity would be 83% instead of 30%. And the same thing goes for the controls. And so this score, although it's been very, very popular in surgical patients, can be used in medical patients. Now, why am I saying that? Am I trying to push all the other risk assessments aside? Absolutely not. If your hospital uses the Padua score, if you use the Geneva score, if you use the NIH National Health System document, if you use the improved D-dimer score or improved score, very good scores with a lot of data. Mazel tov, use those scores. But you've got to use a score. Now, most hospitals can only use one score because if you're going to do this right, not only do you have to set up an algorithm based on the score, but you've got to have mandatory implementation. That having been said, let's go around the world. Look at what was done by the Vietnamese. Over a 2-year period in 4 Hanoi hospitals, they screened 2 million, that's right, 2,795,000 patients with a Caprini risk score. And what did they show? They showed a curve that's like every other curve in the world. And I just showed you one from China. As the risk went up, the incidence of VTE went up. Here, the same thing goes true in the Vietnamese population. And these results, the parallel results are so similar. The numbers may vary slightly because you have a different population, you have a different country, you have different kinds of surgical procedures done and all sorts of different things. But the trend is the same. Look at that trend. Now let's go to Russia. Another center in Russia, Cyril Lobostov and his associates, wonderful young investigator, going to be a real giant in the industry. He and his colleagues have put together some beautiful data, and they had a group of very high risk patients that were operated on, and they screened them all with a duplex scan. And you can see that if those that had a score of 5 to 8, there was 1 clot, and those that had a score of 9 to 11, there were 12 clots. But those that had a score of 12 to 15 had 26 clots. So the incidence went from 1.9 to 26.1 to 65%. Now that's scanned, so there's a lot of clots in there, scan detected. They may not necessarily be clinically evident, but don't focus on that point. That's not the point. The point is, by doing the same thing to this entire group of patients, we get a spectrum of what the VTE incidence is. And again, it's the same curve you see everywhere else. So these studies from around the world reveal a high thrombotic risk with patients with escalating Caprini scores. The data in patients with values greater than 8 suggest extended prophylaxis may reduce VTE events, hence help prevent fatal pulmonary emboli. Unfortunately, the ASH guidelines did not evaluate or comment on any of these data from around the world. Now, please believe me, I'm not saying anything negative about these ASH guidelines. They were a fabulous set of very high-level academic evidence-based data that was evaluated by some of the most brilliant people in the world and put together in the latest update. Unfortunately, they chose not to evaluate or talk about the Caprini data. It could have been just simply, they say, well, the Caprini risk score works now for surgical patients, so we're going to focus on other more important items. I don't know what was in their mind, but this is the reason why I continue to present these videos and continue to repeat this information in order to reach as many people around the world as possible. Now let's talk about pneumatic compression. A study appeared in the New England Journal about pneumatic compression. Now, for years, we've used pneumatic compression. We've used pneumatic compression for patients who are at high risk for bleeding. We've used pneumatic compression for those patients that are having surgical procedures, but the risks aren't that high. So you don't need to use an anticoagulant and risk bleeding. You can use the pneumatic compression. We also know that for years, patients that were at very high risk, we not only gave them an anticoagulant, but we added pneumatic compression to take care of all the factors of Virchow's triad, and that would help lower the incidence of venous thrombosis. We also know, and this is a separate story, that the use of pneumatic compression during operative procedures, especially long ones, is absolutely mandatory to lower the incidence of venous thromboembolism, because all the factors involved in Virchow's triad go on in the patients whose muscles are relaxed and is lying on the operating room table and is there for especially 3 or 4 hours. So now this PREVENT trial comes into the New England Journal. Now, all of us, I'm sure, most of us everywhere in the world, we really respect the New England Journal. And when something comes out in the New England Journal, we pay close attention. And they published this article that came from a number of countries around the world. 16,000 patients, but only 2,000 or so were finally admitted into the trial. But anyway, that's beside the point. What they said was that among critically ill patients who were receiving pharmacologic thromboprophylaxis, adjunctive intermittent pneumatic compression did not result in a significantly lower incidence of proximal lower limb deep vein thrombosis than pharmacologic prophylaxis alone. So in other words, they showed in this study that adding the pneumatic compression to anticoagulants didn't change the incidence of venous thrombosis. It didn't help compared to using low molecular weight heparin alone. Excuse me. So Some of us wrote a rebuttal article, two giants in the world, Andrew Nicolaides and Stephen Keikos, celebrated experts in pneumatic compression and in vascular surgery. Most likely, the delayed application, and this is what they said, most likely the delayed application of IPC in a predominantly medical cohort of patients admitted to an ICU explains the lack of effectiveness, without ignoring the fact that IPC use was also allowed in the control group. The use of a variety of IPC devices, a variable proof of clinical effectiveness, may have reduced further the true effect size of IPC. Nevertheless, most people saw the New England Journal. How many people saw this article that we wrote in the Annals of Transitional Medicine? So no sooner was the ink dry on the New England article, then hospital administrators started saying, why are we using all these compression devices if they don't help prevent DVT? They cost a lot of money. They're very hard to upkeep, and cleaning the machines, especially during COVID. We're going to discontinue them. Well, now, wait a minute. Moscow, Cyril Lobostov and his associates to the rescue. As we already showed you, in Moscow, in this high-risk group of surgical patients, the frequency of symptomatic venous thromboembolism, and this is now symptomatic, was as high as 11%. And those with a score of 11 or greater, the incidence of asymptomatic clots, as we showed before, was very high, 59%. Despite the combination of external compression stockings now, not pneumatic compression, but they were using stockings and low molecular weight heparin prophylaxis. So the physician said, we have to do something about this. This high-risk group, we have to improve their prophylaxis. We have got to do something because 59% is way too high. So what happens if we increase the low molecular weight heparin dose? Well, we could do that, but that's going to increase the bleeding rate. We know that. What about if we combine it with pneumatic compression, despite what we heard about in PREVENT? So they did that. They randomized 407 patients to either receive the low molecular weight heparin alone or combined with intermittent pneumatic compression. All patients underwent blinded duplex leg scans preoperatively, 12 hours postoperatively, and every 3 to 5 days. Low molecular weight heparin prophylaxis was given for at least 7 days, bravo, or more in all patients, and IPC was used for 18 hours daily. What were the results? The scheduled ultrasound revealed that asymptomatic venous thrombosis of the lower limbs was seen in one patient in the combined group of pneumatic compression and low molecular weight heparin, compared to 34 patients in the low molecular weight heparin alone. Highly statistically significant. Furthermore, 5 of the patients in the control group developed VTE and 3 of them died. No PE were seen in the study group, and there were no statistically significant differences regarding skin injury, bleeding, or PE-related mortality, despite the fact that it was higher, though, in the control group. So, what can we take from all of these foregoing data? First of all, the Caprini risk score increases in direct proportion to the incidence of clinically relevant VTE events. Identifying those at high risk according to the population tested and the original concept that everyone with a score of 5+ is at high risk is no longer true. Some patients with a score of 5 to 6 may be spared anticoagulants, as shown by a very nice Panucci meta-analysis published in 2017. And Panucci is a brilliant young plastic surgeon who went back and got the original data sets from 17 of the early trials and reevaluated that data and showed the value of giving this prophylaxis with higher scores, but showed the value of sparing anticoagulants with the lower scores. We know that the set point for high-risk patients needing prophylaxis is varied, and it varies around the world. Studies have now been shown that there's a very high-risk group, those that are over 8, 9, 10 or more, that require extended prophylaxis. So now let's turn our attention to COVID-19. We see that we know that COVID-19 patients, thrombosis is one of the prominent features of the disease. And it's been much talked about. And because of that, physicians treating these problems around the world have been trying desperately to lower the incidence of thrombosis, and sometimes that means increasing more and more the dose of anticoagulation. And so some specific studies have been undergoing to address this question, and one was this large NIH multi-platform. And what they showed in this large study, that full dose anticoagulation was superior to the usual prophylactic dose anticoagulation in patients that weren't in ICU, non-critically ill patients. It lowered the mortality, it lowered the need for organ support, and it also had a slightly lower incidence of venous thromboembolism. However, in the severe patients in ICU, it did not help. It only increased the bleeding. Well, they didn't do individual risk assessment in all of these patients, but they did look at various criteria like high D dimer. But a total individual risk assessment, for example, like a Caprini Risk Score, wasn't done. Now comes, in the heels of that trial, a new trial called Action 21, which is going to be out this week. And this comes out of South America on behalf of some brilliant investigators. One of them is our very dear friend and colleague, Eduardo Ramicati, who's done so many of these studies. And they said that in patients hospitalized with COVID-19 with elevated D-dimer levels, initial in-hospital therapeutic anticoagulation, and they use rivaroxaban once daily for stable patients or enoxaparin for unstable patients, followed by rivaroxaban for 30 days, did not improve clinical outcomes and increased bleeding compared to in-hospital prophylactic anticoagulation. So who are we going to believe? Now, what do we say about this? Well, I would say that it's very important to know that I have no idea. For me to possibly second guess some of the most brilliant investigators from around the world, that doesn't include me, by the way, it would be ridiculous. But I would postulate that without a complete risk assessment, it's very hard to get to the bottom of this, because in ICU, there could have been some very low risk patients otherwise, but there also could have been some very high risk patients that were out of hospital. So we don't really know about this. So my point is, why can't we assess patients with COVID-19 risk using the Caprini Score? Well, for one thing, it's hard to collect those data. And we were talking about how to collect the data ahead of time using patient's involvement. Now, over a year ago, along with some bright colleagues at the American Venous Forum, we put together a series of recommendations, including giving everyone prophylactic anticoagulation when they come in, because at that time, there were not a lot of people doing that. And to consider doubling the dose for scores of over 8, and especially for BMI and heart failure, positive D-dimer, or past history or family history of VTE. And why did we write this? And some people might say, oh, it's just another opinion. Really? For the past 30 or 40 years, what have we known about thrombosis risk? If we have increased risk factors, we have to provide more prophylaxis. In addition to that, rescoring the patient at discharge and using extended prophylaxis for a score of over 8 or other factors, including elevated BMI, D-dimer, limited ambulation, and history or family history of VTE. Very, very important. 1 out of 8 of these patients, goes home with a problem. And we also decided that we should probably have some additional risk scores assigned in this disease, 2 for coronavirus, asymptomatic, add 1 for symptoms, and add 2 more for D-dimer. Another thing that has been missed a lot, which is critically important, and it's not easy sometimes to gather, but you've got to update your risk assessment during the hospitalization, regardless of what score you're doing. You can't just do it once at the beginning. You've got to do it, and especially when they go home. Now let's talk about what was done. Again, back to Russia, Moscow, beautiful series of investigators. They decided to take a look at 168 patients with the 2005 Caprini Score and the modified Caprini Score. And the results identified a significant correlation between the Caprini Score and the risk of VTE and COVID-19. The standard score worked. Sensitivity 73, specificity 96. Score of over 11 predicts VTE. The score of over 7 predicts VTE at 6 months. So the Caprini score worked beautifully. They did a bunch of different models and showed equally high predictability using the standard Caprini score. So they questioned whether or not we needed to add these factors. That's fine. We threw these out as a trial balloon, and it looks like it didn't help in this particular set of patients. Now we go to Egypt, and this just came out. I don't have a lot of details about this, but in COVID-19 patients in this Egyptian newsletter, a score of equal to or over 7 at admission, or a score of equal to or over 11, bravo, they calculated and updated the score as evaluated discharge, predicts symptomatic venous thromboembolism despite pharmacologic prophylaxis. And the predictability of the original Caprini score may be improved by the implementation of D-dimer or specific COVID-19 points. And that, of course, the increasing D-dimer is also a part of both of the scores. And they thought that the original score is essential. So another study that has just been published in the Thrombosis and Hemostasis Open from our own institution was and also from Northwell. Here we have, and I just like to say in the beginning, 2 of the real powerhouses. First of all, I'd like to acknowledge a special acknowledgement for Alex Spiropoulos, who I've known for many, many years and is an absolute giant and done an incredible job with risk assessment using his improved D-dimer models and showing that the risk of venous thromboembolism, both in the hospital and extended out of hospital and in COVID-19, has been very, very valuable. And all of this talk about the Caprini score, I don't mean to undermine or in any way demean what Alex has done, because he's done more work than anybody on this, on his particular scoring system, and it's worked very well. And so he got together with my successor, Alfonso Tafur, who's another young man, just going to be a giant in thrombosis. And the 2 of them are quite a powerhouse. So they put together 184 patients with COVID-19, and they took at a linear increase in scores according to the risk assessment of using both the Caprini risk score and the improved score. Both increased, showed an independent association with increasing rates of VTE and mortality, independent predictors of the results. And these results indicate the value of risk assessment in COVID-19 using either model. And further studies were necessary to confirm these findings and refine the anticoagulant dosing and duration. And I'd just like to show a bar graph of the Caprini score results, and it shows again that same pattern. Does this look familiar to anyone? And what's interesting is that the incidence of venous thromboembolism is almost 30% with a score of 9 or above. And the same thing holds true with the risk of death. And look at the risk of death if the score is 9 or above. It's 80%. Fascinating data. Now, this data we need a much bigger set of data and confirming this in larger studies, and a better selection of the patients and anticoagulation dosing needs to be done. So now, in summary, I'd like to talk about this phrase that was made famous really by Sergio Genzini, and I really would like to acknowledge the wonderful work that Sergio has done around the world to improve the incidence of venous thromboembolism. But more importantly, Sergio and his colleagues have done more to bring people together from everywhere than I can imagine. And we know that never kill a friend, never treat a stranger means performing a thorough history and physical on a stranger when you meet them. So now they become like your friend. And of course, you would never kill a friend because if you would protect them with your thrombosis and of prophylaxis, and you would never treat a stranger because you would not make them a stranger. You would interview them and do their risk assessment. Now, are we treating COVID-19 patients like strangers without individual risk assessment? Please, risk assessment is critical using your favorite tool. Whatever it is, please use individual risk assessment. You will improve the care of your patients. And finally, I'd like to thank you all for your attention. Please visit my social media platforms for more information. And again, thank you, the Egyptian Venous Forum, for the honor of presenting these data. Thank you very much. Have a wonderful day.